Hello, everybody. Welcome to Grand Rounds. We are delighted to have you all with us and pleased to welcome our very special guest, Dr. Eugenia Gianos, who's a professor of cardiology at the Zucker School of Medicine at Hofstra, where she's also the system director for cardiovascular prevention at Northwell Health, the director of the Women's Heart Program at Lenox Hill, and for the Western region through the Katz Institute of Women's Health. She's taking on a number of big international roles as the chair-elect of the American College of Cardiology Prevention of Cardiovascular Disease Council, a member of the board of directors for the National Lipid Association, and the chair-elect for the American Heart Association Clinical Lipidology Committee. And, you know, her focus on prevention is key to all of us. And so we're delighted to welcome her here today. Dr. Gianos, take it away.
Thank you so much for that kind introduction, Dr. Weissman, and for the invitation to speak to your group. This is a multidisciplinary field. Cardiovascular prevention is not just a cardiology field. It really sort of overlaps with internal medicine, endocrinology, and many other fields. So it's a pleasure to be with all of you. So I'm going to share my screen, or at least attempt to do so. And here we go. You're able to see it. Okay, great, perfect. Okay, so again, we'll talk about cardiovascular prevention in a woman really over her entire lifespan. And these are the disclosures for my talk, all mostly from grants for research and moderating talks. And the objectives today are to characterize the hormonal effects on cardiovascular disease throughout a lifetime, differentiate when preventive treatment is indicated during childbearing years, and specifically focus on pregnancy and menopause as important times for risk reduction, and review what management issues are important specific to lipids, glucometabolic disease, and hypertension. And more specifically, we'll go through types of cardiovascular disease and risk in women, different types of hormonal syndromes that we all need to be aware of, breast cancer and cardiac risk, which is a really unfortunately growing area for us all to be aware of, pre-pregnancy risk assessment, management during pregnancy, what kind of changes to expect in menopause, and when to be able to use hormone replacement therapy. So these are a lot of the different areas in women's heart disease that we consider to be a little more of the zebras, I would say. Spontaneous coronary artery dissection, something that we do see actually, and need to be aware of it. Microvascular disease in women who don't have obstruction of their main arteries, but yet still have symptoms. Cardio-oncology overlap that we talked about a little bit. And then really figuring out the risk factors that are specific to women, and some of them actually just carry more weight in women than they do in men. Pregnancy in and of itself is an entire area that we need to make sure we know how to manage safely, PCOS and even the HRT as we talked about. But even though we think about all those unique aspects, the reality is that when it comes to men and women, the most common thing all of us are really encountering in our practices is typical bread and butter atherosclerosis. And sadly, it is still the leading cause of death for both men and women. And unfortunately, we find that we sort of miss the boat a bit with women in terms of not addressing this early in life and trying to catch up, I would say, after the menopausal years. This is an illustration of plaque in an artery that we actually use to teach our patients a little bit about what this process is about, and of the different risk factors that are, some of which are unfortunately not modifiable. Some of the traditional risk factors are noted here, but there's a lot more that we have to keep in mind nowadays: inflammation, sleep apnea, early menopause, complications of pregnancy, some unique factors that really we need to be focusing on in our women. Another really key concept is called the area under the curve. For your exposure to different risk factors. We think about it for pack years of smoking, how long you've had elevated blood sugars, but it's the same idea for LDL-C, I would say. And you can see here that with each quartile of increasing risk, of increasing LDL-C exposure over years, you have a significant increase in cardiovascular event risk. So the earlier we target this process, the better usually women do. And we can't actually just ignore what we would deem to be the childbearing years, because that's a really, really long time. So the 2018 guidelines did a good job at giving you really specific ways to manage patient risk, particularly in the patients who fall outside of the obvious categories. So the ones that have very elevated LDL, that have diabetes, that have coronary disease, a lot of that is very straightforward as to management. But we end up getting a lot of patients who fall into the borderline risk or intermediate risk. And for those patients, one, is always important to have a individualized risk assessment discussion with the patient, and using risk enhancers that are noted here is also really, really important. And when you blow up that little section here, these are factors that we've historically realized that they increase risk, but we now are being told that we should factor them into our decision making. You know, family history of early heart disease, metabolic syndrome, even just being of South Asian ancestry in and of itself, elevated LPA, all of those can contribute to risk. Now, specific to women, though, I would say the inflammatory conditions tend to be a little bit more prevalent, in that women just tend to have a little more rheumatologic disease, rheumatoid arthritis, lupus, and you know, also the other important area is really what's related to early menopause. Premature menopause is defined as specifically under the age of 40. Early menopause might be considered even under 45, but premature is really at quite a young age. And then history of any kind of pregnancy-associated conditions that we'll talk about later, that we've now termed adverse pregnancy outcomes, APOs, and we'll go through a little bit of those. But all of this, surprisingly, should be factored into your decision of how to treat a patient. So talking about a little bit of the hormonal syndromes, one is PCOS. And with PCOS, the issue specific to that is really surrounding the fact that many patients who have PCOS also have metabolic syndrome. And I had asked when the guidelines came out in 2018 why they didn't have PCOS as one of the risk enhancing factors. And they explained, and they're pretty much, as you would expect, correct as guideline writers, that most of the risk that is conveyed is from metabolic syndrome, and that's already there. So if your PCOS patient has metabolic syndrome, then you would be factoring in the added risk anyway. Functional hypothalamic amenorrhea, which is essentially in women who are very athletic or who have eating disorders, who no longer have a regular period because of these different factors. And that lack of hormonal regulation month to month actually leads to a disruption in endothelial function, surprisingly. And then there's premature ovarian failure in terms of having, like we said, a very early menopause. And this is independent, but a moderate risk for ischemic disease. So we should be factoring that in separate from even the other risk factors that may go along with that. And again, like we said, in PCOS, there's more prevalence of CVD risk factors, subclinical CVD, and the degree of CVD risk is mixed, as we said, perhaps depending on how much dysregulation you have in your metabolic risk factors. But really, it's important to recognize those risk factors early and to target them. And this is just a nice depiction of that overlap of how a woman with PCOS has these other things that are going on related to metabolic syndrome that later in life, you know, develops into clinical CVD. But if we recognize it early and prevent that subclinical CVD, then we can really prevent disease. So what should we be looking for? We should really know what all of the basic risk factors are in each patient. They should know their numbers. We should be thinking about a calcium score, even if we're on the fence as to whether to treat or not. And then universally, of course, in all women, we should be prescribing a healthy lifestyle, a comprehensive healthy lifestyle, and then consideration for things like oral contraceptives, metformin that can potentially target the hormonal regulation and then even improve risk factors. So breast cancer and cardiovascular disease, like we know that in the last surveys, the prevalence of breast cancer was something like 1 in 8 women, but we think that it's probably going to even be more common on more recent studies. So this is a lot of women who are coming in, and they don't necessarily have complex cardio-oncology issues. They don't have, per se, a depressed ejection fraction from Adriamycin or things like that. But there are different things in their treatment that, or even their risk factors that put them at greater risk for cardiovascular disease. There are overlapping, so obesity, diabetes, smoking, sedentary lifestyle, all those things are risk factors for both breast cancer and also for cardiovascular disease. So keep that in mind when you're looking for risk factors. And then 2, the treatments they get, whether it's the chemotherapy, radiation therapy, or if they are getting hormone suppression. So that's a really important aspect of breast cancer treatment, is to suppress, if in fact patients have estrogen or progesterone positive cancers, then the mainstay of how you treat those is to knock those hormones out. And when you do that, you have to think, okay, this is to some extent a iatrogenic menopause, right? So then you're looking at what are the risks involved in terms of cardiometabolic risk. So again, showing here that overlap in terms of the common soil of risk factors for the 2 disease processes that we want to even more closely look at for these patients. And then there is the downside of treatment. So radiation, anyone who's gotten radiation, and it really is specific to the left chest. Most of the newer protocols are using, for example, they're doing some of them supine. They are doing breath hold to move the heart out of the way of radiation when they're doing the treatment. So there's less and less exposure to the heart nowadays. But if a woman did have exposure to the heart from radiation, then we should be thinking about premature valvular disease, atherosclerosis, constrictive pericarditis, etc. When it comes to chemotherapies, it's usually the therapies that are the, what do you call them? So Adriamycin and different anthracyclines that are cardiotoxic potentially, that we need to follow the ejection fraction very closely. Trastuzumab, which is specific to HER2, is actually also potentially could affect cardiac function, and we have to monitor patients on that as well. And then the hormone blockade that we talked about, either through medications or even some women end up having hysterectomy and ovarectomy sometimes. And here's just an illustration of the different effects. So the key is that anthracyclines cause oxidative stress, right? This potentially can decrease your pumping function if you get myocyte necrosis. The heart usually has a pretty decent capacity to regenerate cells and repair, et cetera, but trastuzumab, unfortunately, because of its mechanism of action, doesn't allow for as much of that repair. So women who are on both of these end up potentially having even more susceptibility to myocyte necrosis and weakening of the heart muscle. And then on top of that, if they've gotten radiotherapy and they have impaired endothelial function, they can get ischemic heart disease, diastolic dysfunction. So these things are somewhat additive in these patients. What do you call it? So then the pre-pregnancy management. Very important to keep in mind that we're taking care of a lot of women who are trying to get pregnant nowadays, who, one, sometimes are older. Many have risk factors for heart disease. Many are overweight or obese just because of the prevalence in our population. So these are all areas to target. And we know that maternal death is the leading cardiovascular disease is the leading cause of death in women who are getting pregnant. So more women die, unfortunately, of cardiovascular disease than all forms of cancer. And you can see that here, that's why we need to target this. There's not an awareness about this, and we have to focus on it both pre-pregnancy and then after. And unfortunately, these things were on the rise. And then these were on the decline, but more recently, unfortunately, we are seeing rises in all of these, particularly in the pregnancy-related areas. With respect to fertility, there are specific female factors, and it's not isolated to the reproductive system alone. This was sort of surprising to me that there are other factors that are compromising the health of a pregnancy that are actually cardiovascular disease related more so. There's also factors in terms of medically assisted, we're using more IVF nowadays. And so these technologies are also associated with independent risk outside of those specific risk factors. And then again, there's still at the time of fertility, there are women who also have PCOS, so things to be thought about in combination. So cardiometabolic risk prior to pregnancy. So there's certain effects of pregnancy that we expect. We know that heart rate goes up in pregnancy, cardiac output, blood pressure tends to go down somewhat with respect to vasodilatation and improving your systemic venous resistance in order to accommodate for a greater blood flow and to the fetus. So there's a lot of different effects that we see in pregnancy that we should keep in mind at where you should be starting from so that you stay in a healthy range. There are different types of adverse pregnancy outcomes, and I always feel that it's confusing to me when I first learned about this field many years ago. The ones in the beginning here, preeclampsia, anything hypertension related, diabetes, that all made sense to me that those women might be at higher risk in the future for cardiovascular disease. It didn't seem so intuitive that a woman who had a preterm delivery or just low for gestational age, low weight for gestational age, that these things could actually have anything to do with the future cardiovascular risk, but we'll go through why that is. And we know that these APOs are on the rise, they're increased risk for CVD, and there tend to be racial disparities that are important to recognize that we can potentially impact. So the reason for all of this, again, is that there are placental vascular abnormalities responsible for the reason why that fetus doesn't do as well, that they're preterm, that they're low for gestational age, that are related to cardiovascular risk factors. Those same risk factors then put a woman at risk later in life because of abnormal cardiac mechanics, endothelial function, compliance, et cetera, leading to overt disease. So again, we usually make sure to inform women of all of these risk factors. We try to look for them all and we try to target all of them. First step, of course, is lifestyle, something that we probably emphasize as a society in general in terms of how much weight we put into this particular area. But it's so important to realize that there are randomized controlled trials like the PREDIMED trial for the Mediterranean diet that lead to a 30% reduction in an event rate. Something that is better than, in many cases, the drugs that we're using. So this is extremely important to emphasize to patients that the impact of this kind of a diet can be tremendous, both for weight loss, for improvement of cardiometabolic risk factors, and improving even pregnancy chances. The DASH diet, which is a short-term controlled study, relatively small, but also a lot of data to suggest that it improves blood pressure, but also leads to better outcomes in populations where they've sort of applied the DASH diet to see how well people do. So what we teach patients, generally speaking, knowing that all of these different diets, the vegan or vegetarian diet, Mediterranean diet, a DASH diet, 70% approximately of those diets are really the same. It's vegetables, fruits, legumes, whole grains, nuts. So what we do is we try to teach them, just really try to incorporate more of these foods into your diet. We also say what to avoid, processed foods, sugars, sweetened beverages, fried foods, trans fats, saturated fats, limiting all of these. And we allow them to choose, if you can do a vegan or a vegetarian diet and you can do it in a healthy fashion, that's probably going to be maybe even the most helpful to you. You could do a Mediterranean diet, which has tremendous evidence. And these really are all along the same spectrum, in our opinion. With respect to primary prevention, this is the physical activity recommendations that all adults should be getting as a class 1 recommendation, at least 150 minutes of moderate intensity exercise or 75 minutes per week of vigorous intensity for optimal health. And it also does aid with weight loss. It's probably not enough in and of itself, but it's definitely helpful. In terms of lifestyle, also, what's been shown is that healthy dietary patterns up to 3 years before the pregnancy can actually lower the risk of hypertension, hypertensive disorders, gestational disorders, and preterm delivery. And there's a lower odds of preeclampsia in women who follow a Mediterranean style diet. So this is really important to keep in mind. Also, glucose regulation peri-pregnancy is key. Again, knowing that they are at a higher risk of developing diabetes, pre-pregnancy weight loss is key, and suggesting the DASH diet to women with gestational diabetes has been shown to be useful. Metformin is an acceptable treatment that they do use even in pregnancy. GLP-1 receptor agonist is something that we are actually using quite commonly for weight loss pre-pregnancy. And when you get that under control, when you get some weight loss improvement of metabolic syndrome, you can see that the chances of pregnancy are actually improved. So if you can improve obesity, improve metabolic syndrome, then your ability to even conceive goes up. This is another important bit of information. We have actually been using in about a 6 months to 2 years prior to pregnancy, particularly in women who are obese. And some are morbidly obese trying to get pregnant, and that really, really reduces their ability to get pregnant. So we tell them very specifically, we are not suggesting you get pregnant right now on meds. This is just a pre-pregnancy period where we will use GLP-1 receptor agonist for the intention of weight loss to optimize you to get pregnant. And there is data to suggest that it does help with that weight loss. These are now approved for weight loss, as you all know, and for ASCVD risk reduction plus glycemic control. But it's also being used based on some small data for liraglutide, actually originally, in women to conceive, but you should be recommending that they stop at least 1 month before. And this is the study, and there's small studies with low dose liraglutide preconception being superior to metformin alone to increase pregnancy rates. Otherwise, things to keep in mind, although we don't have definite answers on it, it is been shown that sleep disorders do affect potentially pregnancy rates and adverse pregnancy outcomes, et cetera. But we don't yet know that treating them during pregnancy will impact outcomes. It is intuitive to me that, if you have hypoxia repeatedly in the night and you're trying to get pregnant, that's probably not a good thing, but we don't know definitively. And weight loss obviously should be useful for all of the above anyway. Stress, depression, anxiety, all important to be managed. Great. So the last 2 sections are going to be pregnancy and menopause, and we'll just talk briefly about each of those different areas. Historically, we have just not looked at numbers of women in pregnancy, and I talk about this a lot. We put in a small grant at our own institution to look at the pre-pregnancy lipids and tie them to the adverse pregnancy outcomes, and it turns out nobody was checking pre-pregnancy lipids, so we had almost no data to look at. So this is not a good revelation. But in general, right now, the reality is that most people are not going to treat during pregnancy, so they'd rather not check them. So in pregnancy, all of your lipids go up a little bit, including even your HDL. But the average is about 1.5 times their baseline, particularly for LDL. So we expect that as part of a normal pregnancy. And because, like I said, there's not much historically that they've recommended in terms of treatment, the American College of OBGYN has not recommended checking them. There's a large push to change that. And part of the reason, from my standpoint, why we really should be checking them is, number one, if you know that your baseline LDL is 150 at the start of your pregnancy, you really could do things during your pregnancy, eat healthy, be careful about how much weight gain you have, about exercise, et cetera, that you could control some aspect of that with lifestyle. Very elevated lipids can actually compromise the pregnancy, and very elevated lipids can compromise the mother's health. And we'll talk about specific scenarios there. There are actually safe treatments for lipids during pregnancy when they're indicated. And the other thing is that a lot of women just do not present to medical care outside of their pregnancy. Like, they will not go to a regular doctor, unfortunately. So this might be the only opportunity that you have to recognize something that can impact the rest of their life. With respect to the different societies, there's all different kinds of recommendations. Mostly it's, in well-appearing people after the age of about 20, that most societies suggest that you should have some kind of baseline lipid checking, so that if those are normal. There's variation about how often does a regular person have to have their labs checked. Do they need it, every year, every several years, et cetera. And then with respect to pregnancy, if they have risk factors, then the NLA does suggest that they get them checked, with the repeat being at 6 weeks postpartum is what they all recommend, because they don't come down until at least 6 weeks after pregnancy. The multi-society guidelines in 2018 suggested that those with genetic lipid disorder should really be seen by lipid experts, and really be managed closely, particularly severe hypertriglyceridemia, which we will review a little bit. So these are the different types of adverse pregnancy outcomes that we talked about. And as I mentioned before, even preterm delivery and small for gestational age impact cardiovascular events long-term. And there's a compound risk as you go through those and you add them together. You can see that there's actually additive risk that is indicated here. So really important that we ask about those different things. And again, the reason for that is that on the right here is a normal pregnancy. That is a normal uterus. And in the middle here, you can see that this is a ischemic placenta, where there is just not the appropriate development of that placenta to carry a child. And with that, you can see that there's different factors that are involved related to inflammatory markers, endothelial function, adhesion molecules, et cetera. Interestingly, we do think that those same places that we would want to target where this dysregulation is happening in terms of an ischemic placenta are the same exact areas that potentially could be impacted by statins. Something that's unusual to think about, because historically we've always specifically said, please don't get pregnant on statins. This is not what we recommend. But some of the thinking around that has changed. If in fact statins have pluripotent effects, and they can target these specific different areas, that is key. And then the safety has really changed in terms of statins and looking over that data. So in pregnancy, the data we have is always very sketchy because we don't have randomized controlled trials in general. We're looking at lots of observational data, case reports, et cetera. And this here is looking at studies that were specifically looking at using only pravastatin thus far has been used. So pravastatin and rosuvastatin are the ones that are hydrophilic, that specifically don't cross the placental barrier. So those are the ones that are considered even for treatment during pregnancy. And the the reality is that the studies that you can see here are really preventive and therapeutic. They're all small, like you can see 20 to 50 something patients that are used in all of them. And what we learned from that is that in terms of the findings, if patients have been on pravastatin, there's been a trend towards improved outcomes in all of the different findings. And they've looked at a variety of different factors and outcomes, including rates of preeclampsia, of spontaneous abortion, different things. And none of the studies were actually positive. They all trended in the right direction. So none of the studies were positive for treatment of preeclampsia. But when you look at all of the different studies that have been done to date, they've also looked at them just for safety. And it turns out when they look at it for safety from the exposed and non-exposed, there's really no difference, fortunately, in terms of congenital anomalies. So it's just showing more and more that perhaps it's safe to use things like pravastatin in treating women during pregnancy. So to date, it's still recommended that we stop statins. Some say 1 month to 3 months prior to pregnancy and avoid breastfeeding, use dietary counseling. You can actually use colesevelam, which is a bile acid sequestration, and it is safe in pregnancy for women with very elevated lipids. And you can use even LDL apheresis in extreme cases with women with familial hypercholesterolemia, et cetera. And there was about a month ago, or maybe now it's been a few months, the ACC came out with an expert consensus decision pathway for non-statin therapies. And what they suggest is that with patients who have established ASCVD on lipid-lowering therapy who are at very high risk or have homozygous FH, they may be able to continue during pregnancy. And it's got to be an individualized discussion. Then considering apheresis in pregnant patients with FH who have an LDL greater than 300, even though they're on optimal medical therapy and lifestyle therapy. And then if they have FH plus ASCVD, then apheresis can be thought of for greater than 190. So these are not the typical patients that you're coming across. These are rare, but important to keep in mind that if you have a woman and they are out there that are getting pregnant with established ASCVD with homozygous or heterozygous FH, and that we can manage their pregnancies a little better. With respect to triglycerides, also interesting to see that there is an increased hazard ratio for adverse pregnancy outcomes just based on triglyceride levels, quite significant actually. And this is where I think we have the biggest opportunity to act early because, one, they're very, very receptive to lifestyle. So if you knew that you had high triglycerides going into a pregnancy, you would alter your diet potentially to improve that. Two, there are therapies that are actually quite safe during pregnancy. So, one is lifestyle and all that, managing glucose, et cetera. But we could in pregnancy use fish oils, we could use even gemfibrozole, fibrates as needed. But we do run into cases very occasionally where women with some degree of genetic disorder likely end up having severe hypertriglyceridemia in pregnancy, which is really not an optimal situation because this puts the woman at risk for pancreatitis during her pregnancy, which is a horrible situation to have to deal with. So being able to prevent this is huge. With FH, as we talked about before, something important to keep in mind is just that the risk of MI in these patients is 3-fold higher than other pregnant women. Mortality rates are quite high. And this is why we have to think about, do they have established ASCVD already and what can we do differently? And the way to think about a woman with FH is just that she has had these elevated lipids for her whole life in all likelihood. It's a genetic disorder. Therefore, that area under the curve is much higher. So the likelihood is that they have some plaque somewhere in their arteries. And we could use, as we said, some of the therapies that are actually approved in pregnancy. And then lastly, for pregnancy, keeping in mind for hypertension, if you're managing that the best treatments to use really are labetalol and nifedipine. Those are easiest. I would say nifedipine has now become probably the go-to first choice, and then labetalol. Labetalol being twice a day, a little bit less convenient. Nifedipine quite effective. You can still use alpha-methodopa, but it is often 3 times a day, not as well tolerated, not as effective. And lastly, talking a little bit about menopause as we finalize that woman's lifetime here, lifespan. So menopause, and the different effects of lowering estrogen, of estrogen going down in menopause, it's really important to understand that it comes with other annoying cardiometabolic effects, right? Central adiposity, sometimes weight gain, decreased metabolism, insulin resistance. And it's not uncommon. And, for those of you who see patients in this transition period, the common thing we hear is, but my LDL was always 110 and now all of a sudden is 150, and my blood pressures were always normal and now they're very elevated, and same with the glucose, because really that change in hormone level triggers a change in cardiometabolic response. So the one important thing is just that it's an important time to reassess risk. So you have to check the numbers. Even if somebody had normal numbers prior to menopause, we should be checking them again. Then there's symptoms, right, related to menopause that is really important to keep in mind. And I love this little cartoon. I have to run a few tests to be sure, but I'm guessing it's either hot flashes or global warming. And I love this just because it illustrates how many women feel when they come in contact with the medical profession. And for years, we were told as cardiologists, like, no matter what your patient has, don't give them hormone replacement therapy. It's terrible. It increases risk. You should never, ever consider it. Until the fact that these GYNs would find those cardiologists and seek them out that would actually let them give this to their patients. And now we understand that that's actually extremely important. These symptoms are real. They are very life-limiting for many women. And what we should really be doing is assessing risk and deciding who it's safe to use these in. So the ones not to use menopausal hormone therapy in are established CAD, any kind of clot, PE, clotting disorders, any prior stroke or MI, known breast cancer, obviously putting them at higher risk there, or any kind of ASCVD risk that's greater than 7.5. Generally speaking, the recommendation is not to use them there. Then there's the low risk acceptable. So anyone at very low risk, you should absolutely be approving them for that because it's extremely important. And then the ones in between, what we found in general is that if you can optimize risk in that patient and their A1C is at goal and their blood pressure is perfectly optimized and they're on a statin, then you can feel more comfortable that that patient who really warrants the menopause hormone replacement therapy can be safely on them and monitored. So in summary, really lifestyle and screening starting very, very early, childhood and adolescence, using the appropriate risk algorithms to risk stratify a patient, and counseling appropriately during childbearing years. What we usually tell them is, listen, if you decide you want to have a child, we will stop whatever therapies we're using for 2, 3, 5 years, whatever it takes, but let's not miss the boat in the rest of the time, using statins and aspirin when appropriate, using treatment during pregnancy when indicated, and revisiting all of that risk as we talked about in menopause so that we can also use hormone replacement in the right patient. So this is just an example for one of our handouts here in our clinic. These are not things that a patient would even think to tell you about. Like, why would they tell you that they had a preterm delivery or a baby that was low birth weight? You have to actually ask these questions, have them in a questionnaire, and make it easy. Otherwise, you're not going to have the time to go through this with every single patient. There's really great handouts for pregnancy-related issues through CardioSmart, through the ACC, through National Lipid Association. We've created some of our own related to blood pressure and preeclampsia for women. And we really use this. And these, again, all of this type of stuff is available through pretty much most of the major societies, including the ACC and CardioSmart, to sort of guide your patient on this is the process, this is where we want your numbers to be for each of these different risk factors. These are the basics of diet, et cetera. We literally use this to teach the patient at the bedside in 30 seconds and then hand it to the patient so they have some resources. We also created a list of resources of common things that we are sending them for, whether it is for the dietitian or weight loss or smoking cessation, sleep apnea testing. So you should know what your local resources are and how to easily connect patients to them. We also have this Katz Institute for Women's Health, where here we have a lot of programs and education available for our patients to learn from. And then keep in mind that about 50% of women just don't have an internist at all. They use their OBGYN for this purpose. And, it's very varying. There are OBGYNs that I'm in contact with that I'm impressed that they're sending stuff off or they're following up or getting things done, sometimes more aggressively than I would have expected. And others that really don't, I think, put forth a lot of the types of preventive things that we would have wanted for our patients. So keep that in mind. This is just a scientific statement that we had written a few years back, just talking about how we need to use the opportunity for women to get recognized through the OBGYNs in order to optimize their risk. They need teams of care for women's heart centers, all different practitioners. And we should start here very early in life so that we can end up here for all women that are out there. And that is it. This is our team. And thank you for the invitation to speak. And I'm happy to answer any kinds of questions you have.
Excellent. Thank you so much for that. I've already followed you on Twitter and we'll join your Instagram soon. We'll open the floor to questions if people want to enter them in the chat or unmute and ask a question.
I guess I can start off, Dr. Weissman, if that's okay. Thank you so much, Dr. Gianos. Loved your talk and this topic in general. I think so important for primary care physicians, internal medicine docs, to know how to treat women in all stages of their lives. So thank you for that. I guess my question is more about cardio-oncology and some of the novel cancer therapies that are coming out. I know classically we've always related cardiovascular disease, just as you highlighted with anthracyclines and trastuzumab. Is there any data, or what is your take on, screening patients who are on some novel cancer therapies like immunotherapy for cardiovascular risk factors? I know it's a little hard to track side effects that may emerge in 10 to 15 years because immunotherapy is relatively recent. And I think most of the, side effects that we think about are acute myocarditis following initiation of immunotherapy. But what are your thoughts on, getting baseline EKGs, screening for arrhythmias and echoes in patients on novel cancer therapies?
That's a great question. And the field is really growing. What we're realizing, and I do happen to have a lot of colleagues at Sloan as well, just because they were my attendings previously that ended up all at Sloan. So we have these conversations about what we need out there to care for patients. And what it seems is that we need the advanced cardio-oncologists, and there are not a lot of them out there. Not that many that are trained to take care of the patient who has an EF of 35% and it's recovered now to 50, and now you're deciding, should we give them more anthracycline? Like, those are a little more complex. And there are also all these newer, as you said, immunotherapies constantly coming out, and what to look for and what to be aware of. And I think that is one area, almost like heart failure needs the very advanced care people. But then there's the prevention of atherosclerotic heart disease in the cancer sort of survivor that most of us have to kind of manage, I think, in general. With respect to your question, I know for sure that there's even hypertension risks that and specific meds that you should be looking out for even more closely. ARBs and beta blockers seem to have the best evidence in terms of prevention in general, but there's not anything specific with the antibodies that I would say and the immunotherapies right now that I'm familiar with that you should be checking specifically. But certainly women who have had HER2 new trastuzumab need more frequent echoes, monitoring, and then otherwise really like every single one of these patients should be having all of the cardiometabolic risk factors regularly checked to make sure that there aren't changes in those.
Great, thank you so much, Dr. Gianos. Hopefully we'll see more, studies and some information as, the world of immunotherapy grows into other fields.
Yeah, there's a lot out there. So I think, yes, exactly.
Thank you.
Other questions on the floor? Maybe I'll ask while we're waiting. I think we've had a couple of talks over the years looking at some of the, besides lipids, looking at some of the other markers, either, carotid atherosclerosis or LP(a) or some of these other biomarkers for cardiovascular risk. I'm wondering if you could talk about that a little bit, and maybe in the context of whether any of those things respond differently in women or or measure differently in women. Anything in particular we need to be on the lookout for?
Sure. So, there are women who I think have obvious elevated risk that require statin, obviously with a disease in themselves, coronary artery disease, secondary prevention, of course, very high risk based on a risk calculator, but most of them fall into the intermediate range, truthfully, and some even in the low risk, but there are other enhancing factors that still make us concerned, even though they're in that low risk. So the most important ones I would say are, number one is getting a really good family history, which I don't think always happens. So once you hear that 2 or 3 family members had heart disease at an early age, that should change your management significantly. And it is in the guidelines now a enhancing factor in and of itself. 2, we should be checking lipoprotein A, particularly in patients with a strong family history, because that can, dictate higher risk and potentially lead to earlier treatment. Beyond that, I would say my biggest go-to tool is the calcium score. Usually we don't send it off until after 40. Because whatever plaque you may already have is not yet calcified often, but it is a very, very important tool. Being careful not to, if the woman's at higher risk anyway, you don't want to get a calcium score of 0 and then, unfortunately be having an argument against you starting the medication. So you have to kind of convince them that, look, this is important to help us, but you still warrant it regardless. But a calcium score is extremely helpful. HSCRP has been linked to worse outcomes, and in women, it actually is in the Reynolds score, which is a different risk score. There are some who believe very strongly in the value of HSCRP beyond other things. Some of that inflammatory risk is likely due to cardiometabolic disease, obesity, and other things that for most of the patients that I get an HSCRP that's elevated, I've already decided based on a lot of other factors that they need treatment, but it can, if you're on the fence about treating people, it could be something that you use. But I think those are probably the most common things that we use for risk stratification.
Thanks. There's a question in the chat. How do you manage patients who are pregnant but have a history of severe HLD or a strong family history? Good
question. So essentially, if you have a woman that has a history of elevated lipids long-term, it's likely a genetic lipid disorder. That woman has probably been exposed to this for a very long time. And the chances are they probably do have some degree of early plaque in their arteries that they're just unaware of, and it's silent at the time. Some of my colleagues will do a stress test just to know that the woman is safe to undergo pregnancy from an ischemia standpoint. The likelihood is they're all going to be normal most of the time, but are they still at risk? So those major societies are recommending that if it was an LDL greater than 300, to consider apheresis. But even in the lower range, if they have FH, it wouldn't be unreasonable to use colesevelam at this time, which is well called. It also, depending on the patient, one might consider continuing something like pravastatin during their pregnancy. So the question is really whether to, so a woman with ASCVD, like known, plaque in the arteries or some other, then I think that woman should, all of these should be really seen by a cardiologist, really have an individualized discussion. But those women might very well benefit from being on even pravastatin during their therapy, during their pregnancy. Otherwise, for the others with high cholesterol, consideration of even finding out before pregnancy, like maybe getting a calcium score to know If they have a very elevated score, so you know what you're managing during pregnancy is not unreasonable. None of this is in guidelines because there's very little recommendations right now because there's not a lot of data. But I think that, really any woman with a very, very elevated cholesterol or a CVD getting pregnant, somebody should really individualize that decision as to whether to continue treatment.
Great. All right, any other questions out there? That's it. All right, thank you so much, Dr. Gianos. Really appreciate it. Lots of good learning and prevention today. Thanks again for doing this. Hope to see you soon.
Thank you so much for having me. Take care.
Thank you, Dr. Gianos. Take care.